Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is brought to you by AACN's Clinical Scene Investigator Academy, providing the knowledge, skills, and tools to lead innovation, with information available at www.aacn.org/CSIAACN. Now here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
This is Andrea Schmidt, a clinical practice specialist at AACN, and I am joined by this episode's co-host, Dr. Devin Bowers, the Director of Practice Excellence at AACN.
Thank you so much, Andrea. I'm excited to be here today, joining you in this really important discussion that we're going to have with Dr. Lisa Johnson. She's the Vice President and Chief Quality Officer at USC Arcadia Hospital. I had the opportunity to hear Dr. Johnson talk at the AACN's Keck Chapter Symposium, and at that presentation, she was talking about building effective and collaborative nurse-dyad-physician partnerships. During her presentation, what really struck me was Dr. Johnson's use of the term power and her continual encouragement for nurses to own our power.
Devin, I really think this sounds like an interesting topic, and it really seems to be in alignment with AACN's Healthy Work Environment standards. And what specifically comes to mind are the standards of true collaboration, communication, and recognition. And I really look forward to unpacking this concept with Dr. Johnson today.
I completely agree, Andrea. As we go through the conversation with Dr. Johnson, I think you'll definitely see synergies with AACN's Healthy Work Environment standards. So welcome, Dr. Johnson. We're thrilled to have you here today. I think your perspective and your insights are so really important in this space of power and empowerment. Before we really get into that space, could we start off with you sharing a little bit about yourself and your own nursing journey?
Absolutely. Thank you. And thank you so much for having me. As you introduced me, my name is Dr. Lisa Johnson, and I am a proud registered nurse of almost 30 years. I am from Detroit, Michigan. I did my nursing training, my initial nursing education in Grand Rapids, Michigan, Ferris State University, which is started out as a trade university. And so I had the opportunity to, my first program, I was a non-traditional student, but my first program was an associate's degree in nursing. While I was on the wait list to get into the program, I took all the prerequisites, as many nurses are probably familiar with, for my bachelor's degree. So upon completion of my associate's degree, I decided to just stay on instead of going out and getting a position and complete my bachelor's education. So when I graduated with my bachelor's, I felt well suited to join the profession of nursing. But I have to say that over the years, my experience has really highlighted the strength that I gained from having an associate's degree, which is very heavy in technical training, accompanied with my bachelor's training. And so, that was really where it all got started. And in 2000, I took all of that education and training and decided to venture to California. I was a single mom, and I wanted to provide opportunities for my daughter, and there were more opportunities here than there were at the time in Detroit. So that's how I landed here. And my first travel position was actually at USC. And at the time, there were only 2 travel nurses, me and one other ICU nurse. And ICU is my background. I absolutely love caring for patients. And I have the opportunity to not only work at USC, but to also travel across the United States, having that opportunity to practice in New York and Georgia. And so it really gave me quite a diverse experience of what nursing looks like across our nation. I think that really fueled a lot of my passion for nurses really understanding how essential and how powerful our positions are in not only the patient's experience, but the outcomes and the viability of healthcare in general.
Wow, thanks for sharing that about your background, all that great information. Seems like you have so many commonalities with many of the AACN community members who are likely listening to the podcast today. You did both associate and bachelor's program, and we know there are lots of nurses in our community who go that pathway. And there's, as you said, probably a lot of benefits for nurses who that's their career pathway and educational background. And you were an ICU nurse, like many of us. So love the commonalities with your journey and our AACN community who's likely listening today. Why has speaking about empowerment and power become a passion of yours? You shared a little nugget in your introduction, but if you could dive in a little deeper on that, why are you so passionate about this topic of nurses owning and feeling their own power?
Yeah, thank you for asking that question. I would have to say that it's potentially rooted in the fact that I was not only an ICU nurse that felt like a fish out of water coming from Detroit and coming to Los Angeles. I came from a community hospital to an academic medical center. And I also work night shift. So there were a lot of opportunities there. I think that nurses that work in the ICU and at night, and especially those that work in unfamiliar environments, really have to have a strong level of confidence in their practice, in understanding how to navigate systems and resources. And so that really drove, who I was for the first 2 years that I was here in California. I really, while I had the benefit of the community of nurses that I was working with, I really had to make sure that I had a strong infrastructure for myself being a travel nurse. I remained a travel nurse for 6 years. Having a variety of experiences. But one of the things that working at night is that you oftentimes have to, come up with innovative ways of accomplishing goals while still staying compliant with the policy, especially when faced with staffing challenges. And also kind of navigating conversations with physicians at night can be a very challenging path for nurses. And this is really, I think, where I got started, because I understood how essential it was that I was on key and on point with every variable of what was happening with my patient for the entire 12 hours. And when it comes time to collaborate, share information, or give updates seeking additional interventions, especially in an academic setting, sometimes the person you're talking to really does not have the full depth of understanding that a nurse has, being with the patient for 12 hours a day. And so that really started to resonate with me. And I'll be transparent and say that this was also my first introduction to working in an academic setting. So that was the first time that I learned that teaching a doctor how to become a doctor was also part of my job.
Part of your nursing role, right?
So
did they teach us that? They didn't teach us that in our programs, did they?
Right. And so that was a really big part of it, right? Understanding even the power of that. Because as we all know, we're sometimes only as good as our teacher or our preceptor. And if they aren't confident or well-informed, then we run the risk of carrying out things that are not best practice, that are not evidence-based, that are not aligned or compliant with the policy. So it was a whole lot of responsibility, and I took it very seriously, educated myself. If I wasn't in my patient room, I had my face in a book, making sure that I really understood ICU standards and protocols that were either aligned or even went beyond the policies that governed our practice.
I love how your journey started, and I think everybody listening today can probably relate to everything that you have said. And I wanted to just touch base a little bit where you mentioned, that the nurse-physician relationship and feeling like you need to be on your game and you need to be able to communicate everything effectively, which I think can be very scary for nurses, especially a newer nurse, and not knowing what you're going to be met with, right? When you make that phone call, especially in the middle of the night, right? There's the fear of getting yelled at or whatever for making that phone call. So there is a power in that, and then you're also empowered to do it. And so those two terms, how are power and empowerment related? Do they mean the same thing?
They don't necessarily mean the same thing. And I tell you, where I stopped my conversation about my education and background down the lines of speaking about my bachelor's degree, I really became academic about power and empowerment during my graduate studies. As my professor, tasked our entire cohort, right? You have to find that concept that you're going to base your thesis on. And I was very committed that I wanted it to be about empowerment or power. And she tried to dissuade me because she felt like that would be a tall hill to climb, that there wasn't a lot in the literature, in theories, in frameworks that she felt would support my thesis throughout all of the requirements to fulfill my graduate training, right? Because you also have to have a nursing theory that's attached to it. As I began my research, it was very clear why she tried to dissuade me, because the literature that was out at that time, which that was around 2006 or 7, it was there, but it wasn't pervasive. And but I did have the opportunity right through that training to dig into those bibliographies and find something. And that's where I discovered Rosabeth Moss Kanter. And she is a business professor, and she had developed her seminal work from 1977 is a management theory. And it identifies 2 structures to really develop a positive work environment. And those 2 constructs are the structure of power and a structure of opportunity. And so when I looked at that, I also wanted to understand, okay, so how can I make this relatable when it comes to nursing, right? And so when I look at the definition utilized according to Kanter, power is the capacity to mobilize resources. And interestingly enough, if you look it up in the dictionary, if you were to look up empowerment in the dictionary, it says to promote the self-actualization or influence of. And so when I heard those 2 things together, I got very excited to think about who I am as a nurse and how does this relate to nursing. And my takeaway was really that nurses and nursing, we mobilize resources. As care coordinators, that's a huge part of what we do, is that we make the right connections and put the right things together to impact our patient's experience or our patient's outcome, as well as the collaborative relationships that we have. All of those things fall under that guise of a structure of power. So then where does the empowerment come into play? And since the definition is to promote the self-actualization or influence of, this made me really think about Maslow's hierarchy of needs. And so then that made me think about how we approach care in our nursing process and how we think about what we need to do to help our patients to come from that bottom rung all the way to the top of the pyramid of self-actualization. And that's our goal when we have patients in our care. We want to take care of their physical needs, but ultimately we have to treat them as a whole person and as a member of the family, a member of community. And so this is really where it grabbed me. And there's so much to unpack when you talk about power in nursing that it really lends itself to really providing me with an opportunity to influence nurses, to highlight all the different ways that this shows up in our daily work. And I started with 3 main categories of really looking at factors that are affected by empowerment. And one of those is the physician to nurse interaction. Another one is the nurse to supervisor interaction. And then lastly is the interdisciplinary interaction. All of those things. And then they break down even further to really help a nurse to identify how powerful their practice currently is. And I'd love to go into some of that with you, but I'll pause there in case you have another question.
Well, Dr. Johnson, sounds like you have been a trailblazer in the field of nursing in this topical area of power and empowerment, as evidenced by when you were looking at doing your master's degree, you couldn't find any literature that was associated to nursing in this space. So thank you for advancing our profession in that way. I think we'll get into some more of those parallels or those three groups as you discussed as we continue through the questions. Thinking of those three buckets, is there one that's more important than the other?
Ooh.
Or any key takeaway? Like if you had, you have our audience's ear right now. What
Right.
in
Yeah.
those three buckets, like what is the one thing you would want them to remember about the relationship with a physician or their patients or the interdisciplinary team? And it
Yeah.
also serves, we don't work in isolation, right? Healthcare and delivering care to our patients is a interdisciplinary and team sport, as we refer to at times.
Yeah, I think some of the things that I will want to share with our listening audience are the two key takeaways that I shared in the lecture that you heard. One is that nurses are definitely the heart of healthcare. We serve as the facilitators of hope, of excellence in a patient's experience, in the key to successful outcomes, and the ability to bring inspiration and comfort for a patient's quality of life, as well as a patient's quality of death. And those working in the ICU can definitely relate to what that feels like to provide quality at the end of one's life being equally as important as their quality of life while they are vital members of society. For those of us that work in the ICU, we definitely want to provide a good experience, not only for the family, but for the patient. I think oftentimes what we have to deal with at the bedside is more geared towards meeting the needs of the family. And what I do appreciate is when I'm able to ensure and balance that to make sure that the patient's quality at end of life is acceptable and excellent as I can make it. The other key takeaway was that we have to realize and summon our power, right? So there's so many elements and avenues in regards to our being members of the interdisciplinary team, being that key facilitator, that person that has that insight into every aspect of what's happening with the patient, as well as with our supervisors. There's so much power involved in that. And as nurses, we have to really summons that, pair it up with our expertise, our compassion, and our empathy to strengthen our practices from the past into the future. It's really, I couldn't be more passionate about it, but it really helps us to continually evolve as a profession. Once we really understand how key and essential we are to every aspect of care delivery.
I love how you've kind of, connected all these things together, and through your research, you really put teeth behind this concept, which I think makes it so tangible then at the bedside, and to be able to teach people how to do it.
Right.
And also how to recognize when perhaps there's a power play that is negative.
There
right?
you go. Absolutely.
So this brings me to my question that I have. So I would love to know if you have any real life examples that you could share with our listeners where maybe you saw this power play or something being used in a harmful way in the work environment versus a situation where you've seen something that really was productive and positive. If you had one of each, that would be great.
Wow, those are really great scenarios. And one of the things that I like to do, because I do like it to be, I like when I have conversations or talks with where I'm invited. One of the things is to identify some of those key characteristics that you might see when people are operating from a place of powerlessness, because then that helps you to understand what's at play here and the best way to respond. So I'll just give you some. First, I'll start with some of the things that come from Cantor's theory, and that is people low in power tend to foster a lower group morale. Like you've heard before, like misery loves company. And so people that are low in power or feeling a power struggle might be trying to rally others to commiserate and feel like, we've got an issue here. Also, what you might see from those that there's a power struggle is a micromanagement, for lack of a better word, where individuals, because people that are empowered want to pass on the power. They want to empower more and create a cycle. But people who are feeling threatened will tend to micromanage in order to keep a stronghold around the power. You also, for those that are, some of the characteristics of powerlessness might be where you see, I don't want to use bullying, but in 2025, that bullying type of mentality. And I think, we talked about before or earlier about that concept of nurses eating their young. And so we have to understand that if we want to build a generation of strong nurses that understand and recognize their power, that we have to impart our power. And it's not a hazing process, but it's helping them to understand, realizing their power every day. I remember a new grad that when I was working on, doing my research and my thesis, she said to me, would you say that calling a doctor when you have a concern about an order that has been written, such as a potassium order for a patient that's already hypokalemic, would that be a source of power? Is that? And I'm like, absolutely. Because you get to make one of two choices. You just blindly follow the order, or you use your expertise to advocate for the patient. And then you have to also craft the message to correct someone that is the physician for the patient. And what I also like to encourage nurses to do is to call our patients. And when we take that type of possessive affiliation with our patients, then we definitely feel a duty to advocate and make those calls. I would have to say that from the previous examples of characteristics or traits you might see with someone that's powerless, experiencing powerlessness, that the example of either the charge nurse or the manager that is using their power to kind of rule versus to create an environment of synergy and of collaboration and of joy and essentially you have, and I know that as nurses, we can all resonate with, when I'm making my schedule, I'm looking to see who all is working, because I want to kind of work with those people that I have the best synergy with, that, we collaborate well together, we look out for each other, we help each other. But then we have some people that we work with, or different people in supervisory positions, that use that power to kind of micromanage or control. And the reason why I see that as a negative is because then we are minimizing the growth and development that nurses have the opportunity to experience every day that we practice, right? We never stop learning. There's always something new. And I think when we're comfortable in our work environment and with the individuals that we are working with, that it tends to have an environment where there's less risk of errors and missed orders and a number of things that come into play when people are under stress or duress in their practice. And so I personally have seen that, where I've tried to coach and nurture leaders, because some are just brought up in a culture where cracking the whip feels like the right thing to do to be effective, right? But I think as we continue to evolve and educate ourselves, we understand that, you know, there's some truth and some science to saying having a certain amount of anxiety is peak level of anxiety is a good place for you to learn, for you to practice. But stress and duress is a whole nother side of the curve. And that's where we don't want people to be. And so I would have to say that's probably one of the key takeaways that I would like for people to be able to recognize within themselves. I think that's one of step one is to do an assessment of yourself. Do you act more like a nurse that's powerful or powerless?
Let me build on that with you for just a moment, if I may. You've talked about some examples of what it looks like for a direct care nurse to demonstrate or show their power. You said, use the language, our patient, not the doctor's patient, it's our patient.
Yes.
You gave us the example of questioning the physician order. If it doesn't make sense, if you're nervous or clinically it seems out of place, that is a nurse and a direct care nurse showing their power and using their power to question that order. And it's really our professional obligation responsibility, right?
Mhm.
So what are some other examples of if we're put yourself back in those shoes, you're a direct care nurse in the ICU and you are having a really great day and a great shift with your patients and families and effectively using your power, how else will that show up in the day-to-day work of direct care nurses and of our progressive and critical care nurses?
Yes, thank you for that question because there are so many that I think can resonate. I think one of the top and first and foremost that I like to encourage nurses as part of their power being empowered and the power in our practice is to take an active role in their units. You know,
Yes.
we can say that we don't like the way things are running or we don't have enough of this or that, but really we own our practice, but this is our home base. And so really taking an active role in your unit, not just being the person that wants to input comments, but really wanting to be the person that's owning our practices. As a quality leader, I have to contend with, helping to improve and prevent HAIs and things in that realm and complications. And one of the triggers for me is when nurses tell me, well, it was a travel nurse or it was a registry nurse. And I'm not that I'm biased because I used to be a travel nurse, but I was. However, where I am with that is that isn't this your unit? Don't you set the standard? So when people come to practice in your home base, then it is necessary. It's a necessity that they understand what's the acceptable practices, that we follow policies here, that we turn patients on every even hour, that we come together to, ensure that our patients get up to the chair. Those are things that to me highlight owning your unit, as well as being involved in initiatives, unit-based counsel, et cetera. So that's just one. Also, understanding your data. I think that's a really big part of being empowered, because understanding, not just being fed from a leader or from someone else, what are your, especially around those nurse sensitive indicators, what are your outcomes in regards to patients that are under our care? Do we have a good track record around outcomes or around process measures? Have we identified culturally a best practice that fits in our organization? And if we have, how do we spread that information so that others across the organization are able to benefit from that? One of the things that was really a big aha moment for me is that powerful nurses see families as a resource and not as a barrier. That's so huge for me. And I'm just being transparent here because I was not your warm and fuzzy night shift ICU nurse. And I didn't used to guarantee, I never got a Daisy Award, but my patients always got better. But as my career progressed and I began taking care of oncology patients, this is when that key flipped for me. And I really understood how I had limited my power at the bedside by not including family members and caregivers in discussions, in decision making, or just even limiting their time with their loved one. That evolved for me. And so I do everything within my power to try and spread the message of how much families are a resource. I hope people learn that more during the pandemic, when I think the impact of no visitation definitely, in my opinion, as a quality leader, had detrimental impact to things such as falls and simple injuries that frequently family members are able to help us with to prevent, right? I think the other part of that is like your commitment to lifelong learning.
Yes.
Not just based on what your organization is willing to provide as an allotment, but really being committed to how you're growing as a clinician. As I stated earlier, because I was a traveler and I was out there, I had my head in my critical care. Every critical care resource book, I probably owned it and carried it around for the first 5 years. But making sure that we are advancing and that we are even a part of processes of around updating policies. Because we're going to conferences and we're hearing about best practices, right? Or we're hearing about other practices that we maybe haven't implemented our organization, or maybe there's a caveat to the way we're doing or implementing something, and there's new evidence. We get that evidence as we go out, either into your literature, into your academic settings, or into professional development conferences. Huge parts of owning our practice. And then also having open dialogue and collaborative conversations with our physician colleagues and every member of the interdisciplinary team. I remember locking arms with social workers as well as case managers, but more social workers when I was in the ICU setting, because I wanted them to have like a daily responsibility with helping me to navigate the psychosocial challenges that my patients and their families were facing. That was so important to me. And I remember the first time that a social worker saw me reading her note, and she was like, "You actually read my whole note?" And I'm like, "Yes," because that's so important. And I think that highlights another part is, as nurses, when we come on, we have to know everything. And so we've got to have that time to review the chart. It's not when do I have time to review the H&P and the procedural notes. It has to be a part of my workflow, because I can't base my 12 hours of care delivery entirely on what the nurse before me shares. I also need to educate myself based on the patient's record.
I'm
go
listening
on, but I'm going to stop there.
It's such great information, and I'm listening to everything you're saying, and I heard you say a few key terms, and one is, ownership. And part of power is, having people involved. And so I think of engagement, right? So one of our questions that we were going to ask is, how do you teach empowerment to others? And that could be the leader, or who's role modeling that behavior, right? Or it can be the staff. But how do we teach the nurses that part of owning your practices, this is where you get to have a voice, and this is where you get to make the change. So, don't just let somebody come and say, well, this is how you're going to reduce the falls, versus you deciding what's going to work for you. So how do you get that message out there to teach people?
Right. I think that is so important. I think leaders that don't understand the power of informal leaders are not worth their salt, right? Because informal leaders can make or break it. Doctors learn, right, through their training. You can be on the nurse's good side or not so good side, and it's going to make a big difference in the outcomes or the future interactions. But back to your point about how do you teach it? Modeling it, definitely. But I think sometimes we have to be willing to, take a couple of steps back. And myself as a formal leader, right? If I felt like my nurses needed to be empowered and that was a missing link, I would need to sit down and have some dialogue to understand, you know, how are they feeling? And I think one way that we're able to do that in today's day and age, which I appreciate, is that now we have nurse engagement surveys. And those nurse engagement surveys tell us how nurses feel about their work environment, how they feel about being included in decision making, whether or not they are consulted when it's time to look at budget requests for the upcoming year, how we, evaluate acuity of patients. All of those things are places where we are asking the nurse to share with us their expertise. And sometimes it's as simple as making the connection for that nurse to understand those are all elements of power, because they are allowing you and your expertise as a sought after professional to influence how we deliver care. And I think sometimes we're just very focused on the patient, that we don't understand how what we are doing every day when we show up is influencing the greater good. And now 30 years later in practice, I'm very happy to still be talking about empowering others. And I actually have an example from when I was a nursing director, and I had a cadre of nurses that probably had 20 plus years of experience, night shift. And as you know, a night shift could be one of two things. It could be full of new grads, or it could be, a nice balance. Well, it could be one of three things: a nice balance of new grads and senior seasoned staff, or it could be the scenario in which I had, where I had about a 75% skill set of 20 plus years. But there was that 25% that needed to be covered, right? And interestingly enough, my seasoned ICU nurses felt that the nurses of today were unteachable. And I knew that was not true. I knew at some point in time, somebody said that about all of us, right? We just have to put ourselves in that posture to really appreciate that. And so I basically sat down and had a conversation with the seasoned nurses. And I highlighted for them how inspired I am by how organically they care for patients and they solve problems, how organically they collaborate with our physicians, and how much our physicians trust their their feedback, their documentation, their recommendations. And so I just said, like, we're at a fork in the road. And so I can ask you, because absolutely none of these people wanted to precept, by the way, and so I just said, we need you. The nurses of USC need you, because you are the best preceptor to help these individuals to become nurses that will add the complement that we need in order to care for our patients. And if it's not you, and if it's not today, then who is it going to be, and when is it going to happen? And really, it came from a place of authenticity, because I really do value experienced ICU nurses. And I think sometimes sitting down and honestly conveying how much we appreciate their expertise, and actually giving them the opportunity to empower them to prepare the next generation, it's as simple as that. It sounds simple, but it actually has to be intentional.
Dr. Johnson, all of your stories are so inspiring to me. They just make me feel more empowered listening to all your examples and what does an empowered and powerful nurse look like. And I just have to say, you are absolutely an authentic leader. And I think that example of the conversation you had with those nurses of 20 plus years and really engaging them and inviting them into the conversation and helping reflect their own powerfulness back to them is absolutely a spot on example of being an authentic leader. So thank you for that. I do want to go back. I know you talked about those three buckets, and I don't know if that's the right term you want me to use, but the three buckets of the physician-nurse relationship, the nurse-patient relationship, and the interdisciplinary team, and those that you uncovered during your graduate studies. So are there any other insights that you haven't shared around that concept, or anything else from our conversation today that you thought, gosh, I really want to make sure the AACN community hears X, Y, or Z? Anything else that comes to mind you want to share with us?
I think when it comes to thinking about those three buckets, and that's fine, when you think about the interdisciplinary team, it's interesting because in my current environment, we're in the process of we're in a looking at a length of stay initiative, and so we're in the process of looking at discharge huddles and how do we prepare day to day, and who should lead those conversations. Who should lead the conversations when we're rounding, whether you're in an academic setting or a community setting? Is it the physician? Is it the nurse? And interestingly enough, frequently you'll hear people say that it should be the physician, but I've worked with some very experienced physician professors. They prefer to have the nurse lead off in the report because they understand how the depth and the breadth that bedside nurse has in regards to that patient's status, not only their status today, but what preceded today, and building a good snapshot that's going to prepare the rest of that interdisciplinary conversation. So really understanding how influential you are as a nurse to the interdisciplinary process. And I think immersing yourself versus having expectation that others around you are accomplishing their individual parts. I think I really want to understand how we as a team are influencing this patient. If we could get more nurses to operate in that fashion, I believe that we would miss less things, right? That needed interventions or discharge plans or whatever that case may be, I think would be more cohesive when we are at the nucleus of that interdisciplinary team. That's just my own thoughts. Others might think they belong in the middle, but I think the nurse is the key.
Points back to what you said, nurses are at the heart of healthcare.
That's
right?
it.
Yes.
It is. That's my story and I'm sticking to it. When it comes to nurse-physician relationship, I'm going to emphasize again, these are our patients. I think sometimes when nurses call, especially, if you've got a physician that kind of can rub you the wrong way or give you a hard time. It's like, I'm calling about your patient, da-da-da-da-da. Like, no, I'm calling about our patient. And please, I was just reminded of this the other day. Please make sure that we are giving our patients the dignity to use their name. When I was in nursing school, I'm hearing this more frequently now that nurses are referring to patients by their room number or their bed number. And when I was in nursing school, we had to read a book first day of nursing school called Bed Number 10 because it was really helping and it was about a lady that had Guillain-Barré syndrome and how she was locked in, but everyone referred to her by her bed number. And so she was very conscious to what people were saying, right? But she wasn't a person to them. And I think that that's important, not only in our care delivery and our conversations, but even when we're evaluating quality of care. Personalizing that can sometimes be a game changer for us on the clinical side. I remember a time when I was having challenges on one of my units. I was a director, and we were having some challenges getting our central line bloodstream infections under control. So at the next staff meeting, I asked the manager to have everyone bring in a picture of their loved one. And they had no idea why they were bringing in these pictures, right? And then as we sat there and we talked about our HAIs that had occurred while these patients were under our care, I went around the room to ask people how, this person didn't have their dressing changed for 9 days. So Dr. Bowers, if that was, you have a picture of your mom there. If that was your mom, what would your expectations be?
Right.
And how does that influence how we all need to show up when we are caring for our patients? I think personalizing our relationship with our colleagues and our patients to the extent that I have some personal accountability in this every day is really key and essential. And I think that honestly, physicians that witness that with their nurses, they have a very high regard and respect for that. You know, that really shows who we are. I mean, the great part about being a nurse is that people can look to us for compassion and empathy, but they can also look to us for the utmost clinical expertise, right? We have the whole package. And that's probably the best way to kind of summarize being empowered as a nurse. But the last bucket there was the nurse and the supervisor interaction. And I'd be remiss to not touch that one, right? Because that's so key and important. Because ICU nurses and progressive care nurses are such strong clinicians, formal or informal leaders. And it's sometimes quite a dance that we have to engage in because we're so strong, but we have to follow, right? And so sometimes that can be challenging because sometimes our pushback or our advocacy can sometimes blur or cross the line of respecting your supervisor, right? And so being aware and understanding that being empowered is an art. And so you got to finesse it, you got to work it, you got to reflect. But I think when you are talking to your supervisor, this is where your personal accountability is showing up. This is where your ownership is showing up. And not because it's my unit, not you, my manager, but this is our unit. Right. And I want you to know that I want to be a part of the solutions. I've been here, I've been dedicated for 20 years and I've seen things come and go. And so this is what I'd like to offer you. Like, those are the first people I talk to on a unit. Like, I want to talk to the people that have been there the longest, and then I want to talk to the people that have been there the shortest. And somewhere in the middle is going to give me the ideal place to kind of kick off. But I think also not shying away from your natural leadership qualities as a nurse. I think all nurses have to lead. Mm. You're the CEO of your patient assignment every shift.
For sure.
You know, so we have to lean into our leadership qualities and just kind of, you know, understand how to yield that on a day-to-day. And last but not least is that I really want to encourage nurses to be proactive, not reactive. And that's where we'd like to be. And so if we find ourselves every day just in a reactive state, then there's some variance, some gap there, whether it's knowledge or whether it's a system or process issue. But I want us to be able to practice from a proactive point of view.
Well, Dr. Johnson, this was so informative. And thank you so much for spending your time with us today. And it is clear that you are passionate and very knowledgeable about power and empowerment. And I can only imagine the nurses, how much they're benefiting from your expertise in your organization. And I think that's fabulous. And I hope that this helps give others ideas on how they can do that in their organization as well. But before we close today, I have one more question. What is one piece of advice that you would give to a direct care nurse who may feel completely powerless or unengaged? How do you get that individual to flip and become empowered?
Wow, that's a really big question. I want to say a number of things. One, I'd like to encourage people to sometimes not be unwilling to start over. And sometimes we join organizations because it was the first people that made us an offer. But I really want to make sure that we understand that we are clinicians and we are practicing. This is not our job. This is our clinical practice. I have a license that I worked hard for, that means something that I need to protect. And so when I work in an organization, I need to see myself in the mission and vision of that organization. And if I don't, then fundamentally there might be some lack of synergy there. That might not be the best place for you. I don't know. I'm not trying to encourage people to leave where they're working, but that's very important because that should be how your organization operates. Things should feed up to the mission and vision. But secondly, also, identifying a mentor, I think, is so key. My assistant often asks me, why do you keep agreeing to be the mentor for people? And then when I go back to school, my husband asks me, why do you keep going back to school? Are you going to make more money? And and the answer to all of those is I offer myself as a mentor because I believe that that's part of my purpose. And I go back to school because I want to continue to contribute to the growth and the development of my profession. It's not because I'm going to get any more money. It's not because I want fame or notoriety. It's because I really love watching people blossom and to really self-actualization. Wow, you brought me full circle to the definition of empowerment. You just did that.
That's awesome. Well, thank you again for all of your time today. Thank you to our listeners for joining us. As a reminder, we would love your feedback on this episode and any ideas for future episodes. You can contact us at podcasts@aacn.org.
Thank you so much, Dr. Johnson.
Thank you.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's Clinical Scene Investigator Academy, providing the knowledge, skills, and tools to lead innovation, with information available at www.aacn.org/CSIAACN.